The broadcast is now starting. All attendees are in listen-only mode.
All right. Hello, everyone. I'm Ryan Mackman, and I'm a business consultant with Salient Healthcare. I want to welcome you to today's webinar about appropriate HCC coding. Just a few items of note before we get started. I want to inform everyone that this webinar is being recorded, so you'll certainly have the opportunity to rewatch the session, and you'll even be able to share it with colleagues if you want. Salient Healthcare is actually going to email you a link of the recording and the slides following this presentation. Finally, during the webinar, you'll be able to submit questions to other presenters and myself using your attendee control panel at any time. And we'll go ahead and answer as many of those as possible during the Q&A session towards the end. Just know that the questions are also being recorded, so even if we're unable to get to yours during our allotted time, we'll go ahead and make sure to follow up and answer that via email. So presenting with me this afternoon, we have Amy Kotch, our Principal Business Consultant, and we also have Maria Nikol, our Senior Business Consultant. Now, this webinar was put together after several common experiences that we've had with various clients, and we found that we often ended up discussing the role of appropriate coding when managing patients. Part of practicing good population health is getting to know the patient so well that you can anticipate and even get in front of potential health risks before they develop into something serious. An analogy that I like to use is, think of it like maintaining your car. So you go for an oil change every 3,000 to 5,000 miles, and you do that so that your engine continues to run without issues. And you also think to get occasional checkups on different wear and tear parts like brakes, tires, shock absorbers. So when you go for these car checkups, your mechanic is going to run a diagnostic, and they'll determine preventative maintenance that'll keep your car in good health and hopefully help you to avoid a major breakdown in the future. In a roundabout way, that's also what we do in population health, and HCC risk scores play a pretty big role in helping us to accomplish this goal. Now, HCC stands for Hierarchical Condition Category, and these codes help to predict costs for Medicare beneficiaries based on disease and demographic risk factors. Appropriate coding leads to a more accurate benchmark, and in turn, that enables you to both anticipate the actual cost of care and the type of care that your patient population is going to require. Once you have that squared away, it gives your ACO the ability to derive initiatives that'll correctly address other areas such as quality and utilization. But in order to do that, you have to get the coding down first. Here's a little history lesson. So CMS implemented a risk adjustment model back in 2004, and they referred to that as risk adjustment factor, or just RAF for short. Now, a RAF is derived from ICD codes pulled from claims data. Each patient is then assigned a RAF as a relative measure of risk of likely costs of care. And if this sounds a lot like how insurance sizes up probable risks, that's because it is. HCC scores were originally used by CMS so that they could adjust capitated payments to Medicare Advantage plans. And now they're more universally used to assess population health as a whole. If you run an accountable care organization, you're going to want to make sure that your coding's appropriate and accurate, because that's going to ensure that your benchmark will equally be accurate. And that gives you your best opportunity to then achieve shared savings. The financial impact of coding is certainly important to how you run your organization, but there's an even more important reason that focuses on patients themselves. And I'm going to go ahead and hand this off to Amy to discuss that next.
Thanks, Ryan. So let's talk about why coding is so important. The codes used in billing are telling the true story of your patient. This is going to help paint the bigger picture in the medical history, will help providers take care of their patients. You can even save a life or maybe even a limb. Being as specific as possible makes a paper cut a large wound or an amputation not just of any leg, but specifically the left one. Now, additionally, coding specificity helps with payment. regardless of the payment structure that you have, you can still be fee for service, or maybe you have some sort of hybrid payment method within a value-based contract. But nonetheless, the HCC will still help to determine the acuity of illness for your population. Now, the risk scores can help with capitation payments. They can help determine benchmarks and even assist with bonuses later on. Nonetheless, the risk score is paramount when it comes to financial compensation, and so that the provider can properly take care of the patients. So we're going to take a look at two different examples to illustrate how improper coding can lead to lower risk scores, which could really affect how providers take care of those patients and how you might ultimately get reimbursed. So here's our first example. We have a patient who went to the primary care physician, and this patient is a 75-year-old male with type 2 diabetes and a BMI of 40 who has complaints of numbness in his extremities. So somewhat common of a patient. And as a provider, you will have to code this patient, but how do you go about doing it? You will have to address the chronic condition, which in this case is, of course, that diabetes. But it's important to consider if the diabetes has complications or not. And you can see in the two options on your screen how the different options will impact the scores. Now, diabetes with complications have much higher weights to them, and that indicates that the patient has a more complex condition, which requires more time and effort on behalf of the provider, which therefore should be reimbursed at a higher rate so that the provider can properly manage the patient and be compensated for that care. Now, considering this patient has complaints of numbness in his extremities, the provider should probably test for polyneuropathy, which would be a complication factor to the diabetes. The other component to address was the BMI. Now, the patient has a BMI of 40, which indicates to the provider that the patient is in fact obese and should be coded accordingly. The obesity is another factor that adds to the weights. Specificity matters, and it's going to absolutely impact your bottom line. In value-based care, you're treating the patient for desired outcomes. So you need to properly document so that you can anticipate those outcomes and make sure you're taking care of the patients in a proactive manner, similarly to Ryan's car example. So you're going to need to take more resources to manage those complicated patients, and therefore you should be reimbursed appropriately. So let's go ahead and take a look at another sample patient. All right, sample patient 2, another somewhat common type of patient you'll see. This patient is a 75-year-old female who has type 2 diabetes and is coming in for a routine follow-up. Now, she has an HbA1c of an 8.3, and she also has COPD and carries around an oxygen tank. So how do we code for this patient? Now, like the other patient, she has diabetes, so you're going to want to address the chronic condition there. And you might also want to consider that this patient has hyperglycemia, so that would be a complication to the regular diabetes code. And we know that because of the hemoglobin A1C results, that HbA1c test. Now, you'll also want to consider the COPD. So you see we're building on to additional codes. The COPD might not just be COPD. In the two options, you can see what it looks like if the patient just has COPD and diabetes unspecified versus different codes with complications. Now, we know this patient carries around an oxygen tank, so it's not going to just be COPD. She's oxygen dependent, so you might want to consider coding for chronic respiratory failure with hypoxia. And you can see the difference in the RAF scores when you do code appropriately and accurately. So I'm going to hand this off to Maria, who's going to talk about the impact of HCC coding for accountable care organizations.
Thanks, Amy. So there's a significant impact of HCC on an ACO. Presented here, you'll see 3 fictitious ACOs. Each ACO's baseline costs and actual costs are exactly the same. However, due to the coding variations, their risk adjustment factors vary slightly. For ACO 1, you'll notice that their RAF is below 1. ACO 2 is exactly at 1, and ACO 3 is slightly above 1. When we take that RAF and multiply it by the baseline costs, we get that significant variation, which then translates into the last column for a significant variation in savings and in losses. Now, remember, savings and losses are kept at 3%. Now, even if you have an ACO that took great care of their patients but forgot to code accurately for their acuity, you're losing over $16 million, and that's a really significant impact, especially if you're in two-sided risk contracts. So it's important to note that the primary care outpatient setting codes will not be the only codes that are factored in to reflect that patient's acuity. There's a number of settings which the patient visits over that course of the year that's going to be used for HCC, and they're listed here. It's really common for a patient that hasn't actually seen their primary care provider in a while to get a brand new diagnosis while they're visiting the short-term hospital, for example. Now, similarly, there are select provider types that will be responsible for appropriate coding and reporting those HCC codes. On this slide, you're going to find a list of those providers. Now, it's important to ensure that the primary care provider reconciles those codes that have been billed by other providers in other settings. And the annual wellness visit is the perfect time to do so. The AWV, which we covered in a previous webinar that you can download from our website, is really the perfect opportunity to review problem lists and review codes for chronic conditions. The AWV is completed annually by the patient's PCP in order to improve quality measures, reduce churn, increase attribution, as well as accurately reflect the patient's acuity through HCC scores. Now remember, you can only provide a maximum of 12 conditions per claim. So we've had a lot of experience working with ACOs across the country and wanted to share best practices and pro tips with you today based on those experiences. First, as we previously discussed, you'll want to use the annual wellness visit to review problem lists and keep them up to date and accurate. Even if you documented a code last year, it's important to document chronic conditions at least once annually. So for example, if a patient that is a quadriplegic came in last year and you coded them appropriately, the code is not going to carry over into this year, and thus it's going to appear that he's fully able-bodied. Most chronic conditions don't resolve, but they still need to be confirmed annually for coding purposes. Second, it's important to select the most specific ICD-10 and document it in the EHR. So for example, there are plenty of diabetic codes, but you want to pick the one that's most relevant to that patient, since these are the codes that carry significant weights, as we saw from Amy's examples. Third, avoid using the term history of for the chronic conditions that the patient has but are currently stable. If the patient has diabetes, for example, then state so. We're going to take a look a bit more at proper documentation in a few minutes. And lastly, support all codes with documentation using M.E.A.T. Amy's going to speak more about proper documentation.
All right, so yes, Maria did say M.E.A.T, and M.E.A.T is an acronym that can be used to ensure proper documentation. And it means establishing the presence of a diagnosis during the visit. And you'll see more and more that it's important that you can establish these diagnoses during the visit as opposed to later on, because through electronic processing, things are happening at the time of the visit. So it's going to be even more important now. So let's review that M.E.A.T method. M stands for monitor. And that means that you're going to need to ensure that you have the signs, symptoms, and disease progression or regression documented. Then you have the E, which stands for evaluate. You need to review and document any test results, which may include labs or imaging, and you'll also want to identify whether medications that the patient is taking are effective in managing their condition. Then you have the A, that stands for assess. You want to identify whether any additional tests are necessary. You can counsel the patient on whether they need to adjust their regimen or not. And then lastly, you have T, which stands for treatment. And this is where you identify the recommended treatment based on the conditions. So taking this methodology for documentation, let's go through a few examples. So here we have a patient. It's noted they have CHF, chronic heart failure, and the symptoms are well controlled. They're taking Lasix and an ACE inhibitor. The provider notes that the patient will continue current medications. So running through this with M.E.A.T, we know M stands for monitor. We know that the patient is well controlled. Okay, all is well. We don't have any test results to review, but we do know that they're taking Lasix and ACE inhibitors, so they are on medication, and we know that for the E, which stands for evaluate, that there is no additional tests needed or adjustments because the patient is seemingly well controlled. Now for assess, which is A, we know again that nothing additional is necessary. So the recommendation is for the patient to continue their medications as indicated, which would be that T for treatment. Let's go through another example to show you how M.E.A.T works. So here we have a hypertensive patient who also remains stable, who is taking Losartan 100 milligrams daily. So here we have the M, monitor. Patient once again remains stable. We have E for evaluate. We know they're on medications. We don't have any tests here, but they're stable, so keep it up. A, assess. There is nothing else needed, so patient's doing well. And then lastly, you have T, treatment, which is just, again, continue current medications. So you can see that this could become very complex, or it can be relatively simple depending on how the patient presents themselves during the visit. So with that, I'm going to have Maria discuss a few important statistics regarding HCC coding because they're very interesting to listen to.
Absolutely. So I wanted to take some time today to review some national statistics with you. Interestingly, we know that there is an error rate of about 33% for HCCs. Additionally, rural providers serve Medicare beneficiaries with lower average HCC scores than urban providers, a 1.43 compared to 1.75. Now, given these statistics, do you think it's possible that Medicare beneficiaries in rural areas are actually healthier than those in urban areas? Or do you think that perhaps the rural providers are contributing to that 33% error rate in coding? There's actually a website that provides you with information on your regional HCC scores, as you can see from the map on the right. Now, if you wanted to take a look at your specific region, you can actually zoom in, and we have the link provided below. Now, I wanted to bring Ryan back in because he's going to go over how Salient Healthcare can help you ensure appropriate coding. Ryan?
Thank you, Maria. So by now, you realize the importance of appropriate HCC coding, why accuracy matters, and how coding can have a large effect on the rest of your ACO. Now what we're going to do is show you how Salient Healthcare can ensure that you stay on top of coding and how you can get the jump on opportunities for improvement. First, I do want to mention, this is all demo set data. There's no PHI being revealed during my example. Okay, having switched from our slide deck to the Salient Healthcare dashboards, you'll see that by clicking on risk opportunities here in the risk navigation bar will bring us to the risk opportunities dashboard. Now, once this opens up, the dashboard is going to provide you with a detailed view of beneficiary risk based on HCC coding, which is what we've been talking about. The data is organized in such a way that analysts can easily identify outliers with regards to risk and spend. I should also mention here that Salient provides risk scoring updates on a monthly basis. Now that's key because CMS calculates risk scoring quarterly, and the way we're able to provide you your information on a monthly basis is through our own proprietary data enrichments. We also allow you to roll up the scores to the organizational, the TIN, the NPI, and the beneficiary levels. Now, looking at this dashboard, over here on the right-hand side, we have a risk scores widget that contains 3 actionable lists. 1, 2, 3. We have all beneficiary risk scores, and you have the ability to expand your ACO, and that's going to show you all the beneficiaries that it contains. In this case, this particular demo ACO also had United Healthcare and Humana Medicare Advantage data, which is something that we can bring in if an organization chooses to do, but you saw it there before I expanded. And then there's 2 other tabs: beneficiaries with a decreasing risk score and beneficiaries who are increasing in risk score. In each case, these lists can be filtered either by practice or by provider, and that allows you to then export these lists to those who can actually use the data to take corrective action. Now, towards the bottom, I'm going to go ahead and close this panel just to give us a little bit more room to see. And towards the bottom here, you have a beneficiaries by risk range widget. You can use this view to list beneficiary names along with classification of low, medium, medium high, or high. Those who are listed as high are likely candidates for case management, and that's because they might require additional care. The medium and medium high beneficiaries are typically good candidates for chronic care management, and those who are in the lower categories may not have been seen by a provider recently. So what this does is it gives you an opportunity to bring those patients back in for another appointment, and then you can ensure accurate coding. Again, like everything else in the Salient Healthcare dashboards, you have the capability to apply filters to look at specific TINs or NPIs. Now, on the upper left-hand side up here, we have a scatter plot chart, and that shows you risk and spend. Outliers are visible in this upper left quadrant right here, and I can actually rubber band a cohort of them to further analyze what's going on. In this case, I'm going to rubber band those that have a risk score below 2, but a spend in this case above $230,000 about. And when I let that go, it's going to give me that cohort, and that list that's spawned, I can actually then choose a beneficiary to drill into, which in this case, I'll choose Matthew. And that's going to enable me to drill in directly to the beneficiary opportunities risk dashboard. And where we're going now is the most granular level. And now I can actually examine this beneficiary using my last widget, which is beneficiary risk. And that's over here on my left-hand side. Here you have the ability to look at individual beneficiaries by weighted diagnosis. So for those who have had a decrease in risk score, we can analyze those diagnoses that have been submitted to ensure accuracy. By expanding, I can then examine whether or not there are more appropriate codes that could be applied in conjunction with the beneficiary chart under clinical guidance. So as you can see, Salient Healthcare gives you a very thorough look at your HCC coding all the way down to the beneficiary level. So you gain a leg up in assessing how your ACO is doing with regards to appropriate coding, who is being coded appropriately, and whom is doing the coding appropriately. That kind of insight helps you create initiatives that are going to ensure that your ACO is headed in the right direction, practicing good population health, making sure your benchmark is accurate, and then ultimately getting you set on the path towards achieving shared savings. All right, so I'm going to bring back my slide deck now. So there's going to be a quick change, and as you can see, we've wrapped up a lot. I mean, there's a fair amount of intricacy when it comes to HCC risk scores and appropriate coding. While we can't go over every possible detail in a half hour, just know that Salient also provides a helpful resource library for our clients, where you're going to find additional HCC documentation and workflows, as well as a copy of this presentation. Our website is www.salienthealthcare.com. We also have additional literature available on our website if you so choose. And I haven't mentioned this yet, but please don't forget, We offer ACOs a free 45-day trial with your own data, and we'll even run an assessment for you. So if appropriate coding is something that you want to focus on, we can certainly do that. Okay, now it's that time. I'm going to open up the floor, and we're going to do a little Q&A. So if you have a question for a specific person, let us know. Otherwise, we will just assume it is general. And I have a few questions already that have come through. The first question that has come in, it says, are there other risk coding methodologies other than HCC? And the answer to that is absolutely yes. There are others, such as John Hopkins, the diagnostic cost groupers used by commercial MA plans, but the Salient Healthcare base package uses the HCC methodology, but we're happy to incorporate other methodologies that may be preferred. I have a second question here for the group. Do you have a way to address dropped codes, miscodes, or recommended codes? And you know, we absolutely can. Just like the analysis that I just showed, you can previously used to help influence current coding practices, as long as there's support during the visit to back the used code. So if you're inputting codes and have missed any or need recommendations, that would typically come from an EHR where the codes are being submitted through. What our system does help with is identifying codes that have been historically used that maybe don't carry weight, so that the user can further assess the patient to see, you know, if there's anything better, more accurate codes should be used instead. All right, I've got another question here. How do you educate providers, and what are the best practices for workflows?
Thanks, Ryan. I think I'll take that one. So from my experience, it's really helpful to have someone review the codes before and after the patient visit. A physician extender reviews the codes that are potentially recommended by the solution before the visit, so they can review the most relevant codes that are there for the PCP. The PCP will then select the codes that they find most accurate, and then the biller and the coder can review the documentation in the EHR to ensure that the visit has been documented correctly and actually reflects the codes that are being used.
Excellent. Thank you, Maria. And there's one more question that has come in. Looks like I have a lot of patients with high risk scores coming from specialty care. How do I know what the specialists are coding, and how do I reconcile their coding efforts?
Yeah, I can take this one. So in the Salient solution, you are able to see what's going on at each individual visit, and we have a list view that allows you to check on that. And you'll be able to see all of the different conditions that have been coded. So your primary care physician can probably do something where they review the list that has been coded historically, and during a wellness visit or subsequent visit, we'll just go through that list with the patient. So you kind of do a reconciliation that the primary care really confirms everything that they're seeing. And if they see something that they can't confirm themselves, then they can go ahead and reach out to any of those specialists that the patient has seen historically and either gather notes, or maybe they reconcile and say, hey, we actually don't see this anymore, so maybe it is appropriate to not code again. So having that visibility is so important, and being able to review it ahead of time allows the PCP to be in a more powerful position to really take on the reconciliation of those lists.
And we did get in a bunch of other questions, Amy, while you were talking. However, my panel is shrinking it, and so it's hard for me to see. Logan, if you're able to see the questions, can you read them off?
Yeah, sure thing, guys. Just to hop in here and try to get a few other questions in. I know we're running up on time, but firstly, we got a question about, can you clarify the look back years for ACO HCCs?
Yeah, so HCCs for Medicare are calculated using a rolling 12 months, and they actually use a 6-month claim lag time frame, which I guess is kind of complicated when saying that aloud. It's better to draw it out, but they're going to use 12 months of historical claims, a full year's worth, but they just adjust it for that claim lag. So you'll always be slightly behind in how they're calculating the actual number. So when it comes to taking a look at your accountable care organization contract and you have a 3-year contract, the biggest impact you'll want to have is on year 2, because it's work you're doing historically that'll impact that number. And then that second year of your contract number will impact your benchmark for the following contract period. So you're always working behind the realm or the wheel before you actually get to where you need to be. So it's important to just have initiatives that are ongoing, and you'll know that you'll catch up later on. It's hard to be proactive in this effort, but education is key.
Are there some common HCC codes that you see across different healthcare systems that are often undercoded, such as vascular disease or a specific diabetes code?
Sure, I'll take this one. So we see that diabetes is really commonly miscoded, and we'll see the diabetes without complications, which is why we provided that example in our presentation today. The commonly missed codes actually are all in our HCC guide that's located on our resources on the website that Brian had recommended. And it's available to our clients so that the provider has those codes right in front of them as they're coding.
And then one last question, guys. How long does it take for HCC score to be reflected in benchmark for ACO?
Yeah, so I tried to, I guess, answer that in the other question as well, which is it doesn't impact it until later on. Everything you're doing now will impact the future, which is unfortunate when you want to see real-time improvement. But just know that any efforts you're putting forth now will help to adjust benchmarks and your contract benchmarks and everything later on.
And that looks like it from the questions, guys, so I'll let you sign it off.
All right.
All right.
Thank you for all those questions. Yeah, we really appreciate it. And if anybody does have any other questions after the fact or you think of it, we're more than happy to answer that via email. But with that, I'm going to hand this back to Maria to just close everything out.
All right, thank you everybody, and thank you for watching our presentation today. Wanted to look forward to helping you navigate the ever-changing waters of the value-based payment initiatives. We'll leave this slide up for a little bit so you can contact any of our consultants directly. Also, don't forget to follow us on LinkedIn at the address below. We hope you have a great rest of your afternoon.